Dr. Harsoor sir, for the topic Uteroplacental Transfer of Drugs. Sir needs no introduction actually. Sir passed his MBBS from MR Medical College, Gulbarga in 1979. Post-graduation from KMC, Hubli. Sir held various posts in various capacities, from superintendent to the professor and HOD to the director, GIMS Gulbarga. He's been elected national president in ISA, state president, editor Indian Journal of Anesthesia, editor SARC journals, editor Karnataka Journal, and member of various publication committees. He has organized various conferences, and he has many publications to his credit, both international and national publications. Over to you, sir.
Thank you, chairpersons, for that lucid introduction. The topic allotted to me is the fetoplacental transfer of drugs, how they transfer. Greetings from my institution, Dr. B.R. Ambedkar Medical College at Bangalore. So, brief introduction why this is an important topic. If you want to know why it is essential to know this particular date, the 1st of October 1957, probably this is one of the big days that we need to remember, because it is on this day one drug called thalidomide was launched in Germany, which was said that it is completely safe and very effective in decreasing the morning sickness, especially in and also in the cancer pain management. And it was used in a very, very short period of time in more than about 46 countries, just about less than a year. But then what resulted was something like this, a phocomelia. This is a picture of a German film producer, how his limbs were underdeveloped. So also, by 1961, thalidomide was confirmed that it is the biggest cause for the man-made medical disaster in the history. That's what was said. So I think you should know that that Matt Fraser, who was a famous American actor, was with a phocomelia. So this 1960s, when they detected that there is a problem, by that time more than about 10,000 birth defects were already detected, and that was not reversible, and it did not take much time. But then it raised the awareness that there is a placenta is a imperfect barrier to the drug is no more true. So they said there is a possibility of some more transfers happening. So what is this placenta? Placenta is an organ which brings the maternal and the fetal circulations close enough for the exchange of drugs, the gases, and the nutrients which are essential for the development of the fetus. But still, those two circulations are kept completely separate. Unfortunately, the placental transfer of substances and their distribution in the placenta is not well studied, despite the thalidomide tragedy, because the very simple reason is the inaccessibility of this placenta in situ for measurement is a major handicap because of the ethical questions, as well as the present day medical legal issues are so high. So it may not be a practical solution to do in vivo studies. So therefore, we have the scientists and the researchers have developed so many methods for that, and one among them is the use of a perfused placenta, because there is a reason is the human placenta is something very different from what it is there in the animals. It is no more, I mean, it's not a similar to the one, so extrapolation from the animal studies may not be possible. So what the standard one that is accepted is the dual perfused ex vivo human placental model. That is what is globally accepted, and many researchers use this particular model because it gives fairly valid information about the drug transfers and other actions. But limitations do remain because it is not a 100% a correct method, because it is as such not an in vivo study. So what is this uteroplacental circulation? How it is going to be affected? Because you know the human placenta is nearly about 2 to 3 centimeter thick, but then weighing about 500 grams. What is interesting is it has got 15 square meters of surface area, very, very large surface area. it is there. And then on the metal side, the spiral arteries, they pump the blood directly into the intervillous space, and then they return back. And during that period, the exchange of gases and the nutrients which are essential for the growing fetus is met with, and they enter into the fetal circulation through the single vein, that is the one vein that is carrying the oxygenated blood. And then after the oxygen and other nutrients are utilized, the blood returns back to the placenta through the two fetal umbilical arteries. So that's a reverse of what we see in the adults. And I need not stress upon this, the role of PGI2 and the nitric oxide in the the natural management of the uteroplacental circulation, because they have got a tremendous effect. But then what is so important is how the concentration of a drug in the umbilical artery is determined. So you should know that the transfer of a drug across the placenta depends on the first thing is uterine circulation. That is, uterine circulation is again influenced by the uterine contractions. The mother is lying in the supine position, supine hypotension it can cause, or any reason the maternal hypo or hypotension is there, that also will affect the uterine circulation. And some of the disease states, like say for example preeclampsia is there, or any of the altered the hepatic metabolism if it's happening, or the specific function in the liver, that is cytochrome P450 may be affected. So in such a situation, the placental drugs of transfer of drugs may not be the same in the different other patients. And we do see the decreased uterine blood flow even in other circumstances, though the extensively used local anesthetics in our anesthesia practice, they may not make any change in the uterine blood flow. But the spinal and epidural anesthesia, because of its sympatholytic effect, or the laryngoscopy because of the excessive release of the circulating catecholamines, they all can reduce the maternal circulation, and in turn the uterine blood flow may be affected. Even the test dose what we use for the epidural injection, adrenaline, is known to cause intense vasoconstriction, and the uterine blood flow may be affected. So that we need to be a little more careful about that. Not far away is the induction of general anesthesia, because that is known to cause hypotension, or inhaled anesthetics are there. Interesting thing is the oxytocin, which is used for inducing the labor, because it can produce a very strong alpha blocker. It produces intense vasodilatation in some circumstances, and that can cause the reduction in the uterine blood flow. And also the uterine contractions during that may be of course a transient one, but still they do affect the uterine circulation. So all these factors are very, very important, because it is the duration of exposure of this maternal blood with the fetal blood, that's what matters. So the duration is reduced, so that may be the one responsible for the change in the transfer of drugs. And there are certain mechanisms are there. It is not just the blood pressure or the exposure that is important, and this how the drug is transferred across the placenta, you can simply classify based on the volume of the transfer, how much volume is transferred. Either it can be a complete transfer or an incomplete transfer. Most of the classification, drugs follow this, one of the two things, but there is this thing, there is a exceeding transfer also is there. So the fetal concentration will be more than what the maternal concentration is there. That can also happen with the particular drugs. I'm just going to explain it later. And these transfers, they follow one of these four fundamental methods. That's either it can be a passive transport, a facilitated transport, and other things. So I'll just explain one by one in detail about how they are affected. This is the charged substances. Basically, the ions, they diffuse through the lipid membranes and the protein channels in the lipid bilayer of the placental membrane. And the amount of drug crossing depends here on a simple concentration gradient. If the maternal side it is more, the more drug is transferred to the baby. And also, as I said earlier, the time duration, how long it is, there is an exposure between the maternal and the fetal circulation. So that also decides in this, because it is a passive transport from one gradient to the other gradient, it will be moving it. And it follows the simple fixed law of diffusion, where the dissociation constant K is the important factor, and this diffusion constant depends on the drug characteristic, that is like molecular weight, lipid solubility, protein binding, and degree of ionization. These are the four fundamental principles on which the the passive transport and the diffusion constant depends. For example, molecular weight, again, is another law, that is Graham's law of diffusion, where diffusion is inversely proportional to the molecular weight of the drug. See, whenever the molecular weight of the drug is less than 500 Daltons, then it may not be significantly affected. But once it crosses 500 Daltons, this role comes into play. So it may not be transferred as easily as the ones with the. And lipid solubility, you know, is more lipid soluble, more easy to transfer across the cell membrane. So that's a better transfer will be there. And converse is the true with the hydrophilic substances. There, it may not be that easily transferred. And protein binding, as the name itself says, the more drug is protein bound, less drug is available for the free transfer between the mother and the fetus. But then you should remember that it is not a uniform from the first to the last trimester of the pregnancy, because it varies during the different gestational age also will have the influence on the maternal protein levels, and so also the protein binding. For example, in case of a preeclampsia, the albumin levels may be low also. In such a situation, the drug may get affected. And this is another important thing, drug ionization. Of course, being an anesthetist, we know most of the drugs are in both ionized and non-ionized portions, because it is decided by the pK. pK is the dissociation constant, where equal number of ionized and non-ionized portions. You know, only the non-ionized portion transfers across the membrane, and then it gets, to exert its effect, it needs to do that. I think I just need not emphasize up. So these are the factors which affect the passive diffusion across the membrane. And the second method is the facilitated transfer. The name itself says it is facilitated by something else. That is, basically it is a lipid insoluble molecules, because if it is lipid soluble, it automatically gets transferred. And here most of the times it may be temperature dependent and also energy dependent also. And the another method what we call here is a co-transport also. Co-transport is, say, a link to the something else. For example, a sodium facilitates the transport of substances such as amino acids. Along with the sodium, these amino acids also enter in, also known as hybrid system. So this is another one, facilitated one. And the active transport, active is the energy consumption will be there in this, the cellular energy is required. And invariably this is necessary because it works against the gradient. So the maternal concentration may not be in a significant quantity, but still it needs to be transferred across to the placenta, fetus. So the energy is required, the ATP will be involved in this. And the last method, that is pinocytosis, though it is just to complete the methods, it is not a significant one that happens. The drugs, they may get engulfed into the cytoplasm of the cells and then transferred across. And one that is said is immunoglobulin G, that is one is transported, this one is identified by this method. But anyway, it is not a clinically significant one. Okay, so coming to the drugs that are used in anesthesia practice, just briefly I will mention about them. Of course, local anesthetics are one of the drugs which are extensively studied. And the determinant factor, as I said earlier, the degree of ionization is the important factor. But then once the local anesthetics enter into the fetal circulation, if there is a fetal acidosis, there what is a phenomenon known as ion trapping may occur. That has to be remembered. And the other factors are also protein binding. Already I told you, more protein bound, that is for example bupivacaine, less drug is likely to be transferred. Lignocaine, for example, it is less protein bound, that is 70%, so naturally the FM ratio will be little more, 0.57. Ropivacaine, again it's a little safer drug, that's all we can be say. It is the same as the other predecessor. Coming to the morphine, some of the things I need to tell you, it readily crosses the placenta and the FM ratio is as much as 0.6, but what you should remember is it has got a very slow onset of action, so titration becomes very difficult. So therefore we need to be very careful when you are using, if at all you are using a morphine in the laboring mother, we need to be a little careful. And pethidine, if not commonly used, but those who are using it, it is available in India. It is a notorious drug because it produces the FM ratio exceeds more than 0.6 to 1 sometimes. And this happens nearly about 2 to 3 hours after the administration. So you think that everything is fine, the FHR is good, but then you may end up in trouble. So therefore, this is one thing very special. We need to remember it happens after some time. So that's a thing we should remember. And fentanyl, you know, it's quite a safe drug. And placenta itself acts as a depot, though transfer is possible. So much of the drug is not transferred to the fetus. So fentanyl, of course, not much is available. I think about 10 years back it was there. And remifentanil, there is no fetal effects are seen with this, though it is quickly metabolized in the maternal blood itself. Then butorphanol probably is quite safe drug, what is said. Thiopentone, induction drug, and the propofol, both of them, they may cause this thing, and temporarily they may cause the neonatal depression, but not a very significant one in clinical practice. Ketamine is, again, it readily crosses, but may not be much effect. Diazepam is another deadly drug because it crosses and it can produce what is typically described as a floppy infant syndrome. Madam, I need just about 2 minutes more. And also it can cause what is known as a cyclical depression, that is enterohepatic circulation, recirculation is taking place, and that will be responsible for this cyclical drowsiness in the newborn also. Midazolam is the same as the diazepam, the effect is same. We need to be very, very careful if you are using in the laboring mother, because fetal neonatal depression is very, very common with these drugs. And volatile anesthetics, though they are highly lipid soluble and low molecular weight drugs, drugs like halothane and isoflurane may theoretically cross, but then not much of a clinical effects are seen. And there are no reports as such published in the literature about this. And muscle relaxants, yes, they are quite safe. It is very, very unlikely that they cross the placenta because most of them are highly polar, that is what soluble substances only. And other drugs, yeah, I want to just make a mention. The atropine, this is a lipid soluble drug and it is seen about almost 0.93 when compared to the glycopyrrolate, which is commonly used, which has got a FM ratio of 0.2 only. So therefore, that means the atropine can cross, not the glycopyrrolate. So therefore, when you are using neostigmine, though it is a quaternary ammonium compound, being a small molecule, because of its molecular weight, it can cross into the fetal side and neonatal bradycardia is a possibility. So it is a rare possibility, but still it can happen. Therefore, if you are mixing neostigmine, better mix with the atropine rather than glycopyrrolate. This is what is the recommended one. So preferable, use the word, because it may not always happen. So to summarize, the major function of the placenta is to transfer nutrients and oxygen from mother to the fetus and assist in the removal of waste products from the fetus to the mother back. And the impression that placenta forms an impenetrable obstacle against most of the drugs is now totally false, because there are various factors which govern the transfer across the placenta, and all drugs administered to the mothers have the potential to cross the placenta and reach the fetus. So no drug is exempted from that. And possible factors determining the extent of the placental transfer I have just already enlisted. And facilitated diffusion is a minor mechanism, so let's not discuss too much. And the phagocytosis and the phagocytosis are too slow to be acting, so they also do not need much of the attention. We must focus mostly on the passive transport and the active transport. So thank you very much for your patient hearing. These are some of my references. Thank you once again, Mysore, for having given me the opportunity to speak and stand in front of you. And wishing you all a Independence Day in advance. Thank you.
Thank you, sir.